Okay, so I'd like to welcome everyone tonight. We're very excited. Oh, did we lose our speaker? He was on, maybe he dropped. So if so, let's give it, oh, here he is. Okay, we want to welcome Dr. Ganesh Gapalakrishna, who's a board certified geriatric psychiatrist and dementia specialist working at Banner's Alzheimer's Institute. He completed his training in adult psychiatry at the University of Missouri, Columbia. While practicing inpatient psychiatry as a teaching professor in Missouri, he completed his master's in health administration. He later graduated from the geriatric fellowship at Vanderbilt University. He has published peer-reviewed articles in psychiatry related to administrative psychiatry, schizophrenia, and dementia. He currently specializes in providing multidisciplinary care to patients with dementia and their families. He is the program director for geriatric psychiatry at University of Arizona, Phoenix, and serves as the clinical director at the Banner Institute. I had the pleasure of going on a tour over there and meeting and talking with him and others, and it was really a very thought-provoking, interesting tour. So I thought this would be of interest to you. So with that, I turn it over and I'll monitor the queue to see if I see any questions or hands popping up. But let me turn it over. Thank you.
Great. Thank you, Lori. Thanks for the introduction. Unfortunately, I didn't listen to most of it because I was in and out of the Zoom meeting. It just kept kicking me out or I was dropping out. So if that happens, I'll be back. So just a heads up. Okay. Thanks everyone for joining. I know it's 4 o'clock hour where nobody wants to work and we're heading into a long weekend. I appreciate you all taking time to just understand about Alzheimer's and dementia and a little bit outside of that too. So I'm just going to talk briefly about what these terminologies mean and what some of the major changes that are happening in our field of with Alzheimer's research. So with that, I'm sorry I cannot project it or share it on Zoom. So this is the best I can do. Are people able to see the slides?
Yes.
Okay. All right, great. So whenever we think about cognition with people, we think about this paradigm that we're going to come back and forth. On someone with a normal aging process, we think about something that goes along the solid line. There's going to be some changes. This makes it look like it's a decline, but in a way it is decline. But there's almost like a shift in the way cognition works as age progresses. So some of the things change with aging, but overall, it's not very drastic. On the other side, if someone has Alzheimer's, they have this prolonged phase called the preclinical phase, which is really important for us right now, where there's not a whole lot of symptoms. People are not experiencing any problems, but the changes are happening within the brain. And now we have mechanisms to detect those changes. Then it goes into this phase called mild cognitive impairment, then goes to dementia, and there's a decline, an ongoing decline over time. So there's a continuous decline. So with age-related changes, the stuff that we expect with aging is that people may start having problems with multitasking, and this is dividing attention. It's not sequential attention. It is if you were to be traveling down a highway and you're listening to music and you're talking to someone on the next to you and you have to take an exit, you will probably be able to do those things in your 30s, 40s, but it's going to get more and more challenging in your 60s and 70s. You'll have to say, be quiet, turn down the music, and then take the exit and probably come back to one of those. So it becomes more challenging with multitasking. There's some mild changes in memory with minimal progression over time. Maybe they have lapses in remembering some information. They may have okay, what is that person's name who came to that party? And eventually it comes to them. So there's eventual retrieval of that information. They may also have word finding difficulties. So they may blank out on identifying one word, but eventually it comes to them too. And we do, with people living longer, we see some of these long-standing ADD, depression catching up with cognition too. So you will see some of those deficits kind of play out more and more as their cognitive uh, reserve goes down over time. But the main thing is this bottom part. None of these things are going to keep someone from being functioning and being independent in what they do. Now, that is the solid line. So now we're going to talk about this dotted line where things are going to change. So we will go back to, we talked about the preclinical. We're going to jump into the mild cognitive impairment piece. So the mild cognitive impairment is like a gray zone. We have people who have no symptoms and we have people with dementia. The mild cognitive impairment is right in the middle. So it emerged as a concept in 1980s. We thought this was only related to Alzheimer's, but since then we have kind of come to realize that there's a lot more diseases that can present with mild cognitive impairment. So it affects about 8 to 10 million Americans, um, annually, and it, it is defined as impairment in one or more cognitive domains. So this can include memory, language, attention, executive functioning, which is ability to plan and do sequential tasks. So it affects these cognitive domains, and there is a clear change in their cognition from their previous level. And this can be either identified by someone close to them, like a family or friend, has noticed that he's not the same as he was before, that like he's having some problems. And or it can be identified by a provider in the clinic because they are performing in a lower range, like we can do some tests and identify impairment. But the key thing is the functional capacity is largely unimpaired. They are really independent. Um, Things like um, driving, cooking, managing finances, managing medications, those things are not affected. They're still able to do all those things. They may need more time. They may need a little bit of assistance. They have to put probably more effort, but they are still able to be independent in their functioning. So that's what we call as mild cognitive impairment. Now, with respect to like what happens to these patients, um, more likely than not, especially when a disease like Alzheimer's is causing the mild cognitive impairment, they're going to progress over time and eventually progress to dementia. But not everybody progresses. About 15% progress every other year or every year, and about 15% may not progress at all even after following them for 5 to 10 years. And rarely, some people may actually even get better, again, based on what's causing the mild cognitive impairment. So sometimes the MCI is caused by depression, vitamin B12 deficiency, hypothyroidism. So once you correct them, some people may actually get better and go back to being normal. So it's really hard to say on an individual level what is going to happen with that person. But it's important to just monitor over time. Now, um, we this was a very big topic initially as to why even bother identifying these people with mild cognitive impairment. Now we have some medications which we can prescribe in these patients with mild cognitive impairment. But even without the medications, it is a very disconcerting issue. Like people may be like, why is this happening to me? Is this aging? Like I cannot do these things, and it can be very disturbing. So making sense of these signs and symptoms can be very relief providing for these patients. They can also understand prognosis, what to expect in the future, and possibly participate in future care planning for themselves so that they can identify what they want their life to look like once things progress or if things progress. There are also some lifestyle factors that can have some good beneficial effects in slowing down the decline in the future. Okay, so now dementia. So this is the second part. I'm going to go back this year. So we've covered mild cognitive impairment, and now we're going into dementia. Dementia is a syndromal term. It doesn't tell you what caused it or what's going to happen in the future. It's kind of like saying cancer, right? So it just tells you a clinical state. this is where people have a progressive decline in someone's memory, language, attention, executive functioning, and it impacts their functioning. They're not able to do certain tasks that they were able to do before. They're relying on family for managing their medications, finances, driving, those type of things. So when those functioning gets impaired, we call that as dementia. They're almost always accompanied by disturbances in emotions and personality. Sorry. They can eventually cause neurological dysfunctions like difficulty swallowing, gait problems. That eventually is what leads to a lot of deaths in dementia. But per se, it takes a long time for progression of the disease. The average is about 4 to 8 or 4 to 6 years from the time of diagnosis to death for dementia. So a lot of times other causes may cause the death, but when it is caused by dementia, it's often related to these neurological dysfunctions. Now, what causes dementia? And this probably could also be applied for mild cognitive impairment. But you can see that right in the middle is Alzheimer's. That accounts for about 65% of the disease, 65% of dementia patients. And these numbers are related to people who are more than 65 years of age. Less than 65, dementia itself is less common, but also Alzheimer's is is still a predominant player, but not like the way it is here. It may account for half or third in people less than 65, but more than 65, it's the biggest contributor. And then on the other sides, you may have people with vascular dementias. These are people who have had either strokes or they've had some major vascular damage in the brain that leads to dementias. The other side, you have Lewy body disease, Parkinson's disease related dementias. Lewy body is another 10 or 20, 10 to 25% contribution. Then there are less common, rare, not yeah, kind of less common varieties of frontotemporal dementias, CJD, which is the mad cow variant of a disease, corticobasal degeneration, and others. Now we are going to just talk about like, oh, sorry, Lori, go ahead.
Just a question. I've gone through Uyghur Mercy, couple tours helping Lisa Cook, who was the director there and the inventor of that concept for that dementia program on, off Orangewood and I-17. And what I noticed, which was really disheartening to me as I went through with other people several times, was that I knew some of the people in there. They were brilliant physicians that my husband used to work with, and some of them were young. So I wonder if people that really are very learned, maybe, and I've seen physicians and attorneys and others, is it just that they notice the deficit and the difference quicker? But they almost had a couple of the homes were full of physicians, and I was surprised by that.
Yeah, it's not like physicians get more dementia than others.
I know. It's strange.
That would be very ungratifying for me to be even in this job. But so people who have cognitive reserves high, like, and we will get to that in the next slide too.
Okay.
People who tend to have high cognitive reserve tend to fend off dementia for much longer. But what we often see is that they're able to compensate really well to one point, and then it's almost like a sudden decline after that. Like, right, like, I mean, it's like a straw breaks the back, and then it's suddenly much more difficult. But actually, people people who have higher education tend to have lower risk of dementia. So that's one of the protective factors. So here is so now we're going to talk just about late onset Alzheimer's disease, which is, when I say late onset, it means people having symptoms after the age of 65. And this is kind of the distribution. So the essential part of this slide is if you have a brain, you are at risk of Alzheimer's. So people who at 65 to 75, there is a risk of about 5 to 9% in those years of having dementia. And as the every 5 years, the risk doubles basically. And here, more than 85 years of age, the risk is about 4 to or 1 in 2 to 1 in 3 at the maximum having Alzheimer's dementia. This is just the severity ratings, the gradation, but it's very common. So the biggest risk factor for Alzheimer's is age itself. Um, Genetics also plays a role. The most popular or like a most important gene, a risk gene that we've identified is this ApoE gene. So we all get one copy of this ApoE gene from our father, one copy from the mother. It really helps regulate the lipid metabolism in our body. So there are 3 types of this gene, 2, 3, and 4. The one that has shown higher risk of having Alzheimer's is the ApoE4. So when people have one copy of this, the risk goes up about 2 to 4 times. If they have 2 copies of it, goes to 8 to 10 times the risk of having Alzheimer's. It doesn't guarantee people having Alzheimer's, but it makes the risk much higher. On the other side, the ApoE2 gene can actually be protective. It can reduce the risk of having Alzheimer's. This is a rare Icelandic mutation that blocks the amyloid cascade. I will go over amyloid as to what that is in a bit, but it can actually make you immune to Alzheimer's. So we think that Alzheimer's happens because of a combination of genetic and environmental risk factors. So one of the main environmental risk factors we have already reviewed, which is age, which is non-controllable, right? So the others are mental activity. So like I talked about, people who have college education are at lower risk of dementia compared to people who have a high school level education. We think about this. We think this is related to cognitive reserve. People tend to have used more of their brain through their lifetime, and they tend to have better cognitive reserve. Same thing goes with occupation. People who have had a high level job or like who been engaged in a white collar job compared to a blue collar job tend to have less dementia risk. People quitting smoking at least by midlife tend to have better outcomes compared to people who continue to smoke. Aerobic exercise is one of the biggest protective factors. So even starting from 40s, 50s, people having to spend at least 30 minutes a day of good amount of moderate level intensity workout tend to have less incidence of dementia when they grow older. The Mediterranean diet has shown to be the most effective and most beneficial thing for cognition. So less red meat, more white meat, nuts in your diet, olive oil, greens, leafy vegetables, fruits are really important in the diet. This alcohol intake is kind of like there's evidence all over the place. But one consistent theme has been that moderate level alcohol use, and again, how you define moderate has been very variable. Moderate level alcohol use can be actually beneficial compared to even not taking alcohol. But this is very disputed category territory, so don't go drinking wine now. The other things is to avoid bad things, right? Like avoid head trauma, control blood pressure, cholesterol, and diabetes. So all these things tend to have good beneficial effects. Well, let me ask the group a question. What do you think has happened with the incidence of dementia over 20 years, of Alzheimer's over the 20 years?
It's
Incidence as in
increasing.
it's
I think
increasing.
it's increased a lot.
Yeah. So
Diabetes has increased a lot.
yes. So here's the surprise. It's actually gone down.
Wow.
So
Oh.
the incidence, which means that number of people in 100,000 people who get Alzheimer's has actually gone down over the last couple decades. But the number of people with dementia has grown up, right? Like, I mean, because we have an aging population, even if the rate is going down, the numbers just keep going up. Part of the reason why we think this has happened is that we've done better on controlling blood pressure, cholesterol, diabetes over the last many years. And also people are more educated than they were 30 years ago, 40 years ago. right? So we have a cohort effect coming in there too. All right, so I will have to pace myself up a little bit. The Alzheimer's, so why we think this happens, we have two main proteins to blame. Amyloid, this accumulates outside the brain cells, and they form the plaques. And then the the tau protein, which accumulates within the brain cells, and they form the tangles. So you would have heard about plaques and tangles, and that's what causes the Alzheimer's disease. Causes inflammation, shrinks the brain, make it difficult for it to function, and eventually causes degeneration. So this is a slide we'll probably come back to later, but I want to just emphasize one important point. This is where all the clinical symptoms are happening, this green zone here. But now all these changes where we can measure in the CSF, like in your the spinal fluid, or we can do a PET scan of your brain and find out the amyloid increasing. Look at that. That's about 15 to 20 years before the onset of symptoms. So we can detect some of these things way earlier. Even an MRI, very high sensitive thing, we can start identifying some changes. They're not very specific, but my point is changes are happening in people's brain way before the clinical symptoms. So just to sum up, we've talked about this dementia, cognitive impairment and functional decline. MCI is cognitive impairment minus functional decline. And preclinical AD is people who are having Alzheimer's disease in the brain, but they don't have the symptoms yet. They don't have any problems with functioning either. So typically what happens as to how they present to us is the family kind of catches on something early on. They have something like this, something going on. I don't know what it is. I cannot put a finger on it, but something's not right. So this is kind of oftentimes the family's first response, or they may say, yeah, this is odd, but who knows? Maybe things will get back to normal. And this could last for months and years. And something happens suddenly. Like yesterday, I saw someone, and this lady was working in, I think Motorola for 30 or 40 years. She finished a shift, 12-hour shift, went back home, and then she said, I need to go back to work. So she came back to work, and the workplace was like, what are you doing here? And then they got her into the hospital. So that was like a clear distinguishing point for them. The family got her into a neurologist office. So that kind of starts triggering the whole chain of events. Or sometimes it may be just getting a new technology. Like, you go from a flip phone to a iPhone, suddenly people know like you're really struggling, but that's not the phone's fault. It's just that things have just gotten more obvious now. Or oftentimes what happens is the spouse dies, and now suddenly the family is dealt with this new situation which they didn't know because the spouse was really compensating. So that's kind of like oftentimes where they make an appointment, or they have a visit to their primary care, and the process starts. So typically with our clinic visit, we would take a history, do a focused neurological exam. We're looking for any evidence of Parkinson's or stroke in that. Do a mental status exam, think about like how their thought processes, speech is. We would do some lab work. Once I'm done with this first half of this slide, I would tell them I want you to do three things. One is lab work, do a neuropsych assessment, which is this big battery of tests that we would do, and do an MRI of the brain. We are looking for strokes, bleeds, and stuff like that. Here's kind of an example of a brain MRI. On the right side, you will see or left side is the normal, right side is the person with Alzheimer's. You can see that there's so much more gaps, like this black spaces, because the brain has shrunk and it has kind of made it more space for for just the fluid around it. And these are called the hippocampi, so they shrink quite early in the process of Alzheimer's disease. Now, the other thing that happens with patients with dementia is that the neuropsychiatric features, like neuropsychiatric symptoms, are very common. If you look at like the nursing homes, it's almost 90 to 100% of the patients with dementia will have some type of psychiatric symptoms. especially if you include something called apathy, where they have no drive or no inclination to do things. It's almost universal. It leads to greater impairment in activities of daily living. It affects their quality of life, leads to earlier institutionalization, like placement in nursing home or a group home. It's a major source of caregiver burden. Someone having a cognitive impairment is a big deal for a caregiver, but then you add someone getting agitated, psychotic, depressed, it's a big caregiver burden problem. It also adds cost for the whole healthcare itself. And you will see that it accelerates the mortality, like people tend to have more disease and die too, and this affects even the caregiver, unfortunately. So this is one of the popular questions that I get asked. Can I take the supplement I don't mean to pick on Costco or Target, but I took the supplement from Costco. Is this going to help my cognition? Generally, the consensus is no. There's not really much of evidence that any of these supplements help people. So I often tell people not to waste their money because these are expensive. They don't really help. There's no evidence actually in either preventive cognitive decline or treatment in patients with dementia. So one exception is this Cosmos web study that recently showed that the Centrum Silver actually improved memory among older adults. This is a very widespread problem. So even FDA warned these 17 companies not to promote their thing as supplements. So we're going to start off here for the recent updates. So you remember this slide. This is the symptoms. We have all these opportunities to identify people way ahead of the onset of symptoms, about 10, 15 years before. So now the exciting piece. Rachel, go ahead.
So I have a quick question on the previous chart. Yeah. So are those like just risk factors, or if you test positive for one of those things, like it's coming and we know you're going to develop this in a matter of 10, 20 years?
Great. There's your answer.
Okay.
So it can, okay. I like that. You're thinking ahead. So these tau levels, so we can even test these. This p-tau 217 is one of these markers. We can even test this in blood now. There's a couple of them who have the FDA expedited process, so or the accelerated process. None of them are approved by FDA, but we are using them in research routinely now. So they can predict people having these changes. They tested p-tau levels, and in 20, 30 years, they saw what their brain looked like on autopsies, and they can predict very good as to who's going to have Alzheimer's in the future. They can be detected about 20 years before the onset of symptoms. So they have this breakthrough device designation, and they can become like the cholesterol of Alzheimer's, right? Like people, they can get this test done by the primary care office, and if we have interventions, it would be easy for us to intervene here. We can also look at the amyloid marker, so the A-beta 40 by 42. We can also tell us how the PET scan is going to look like. So in 2023, FDA approved this first diagnostic test for amyloid plaques. This is a CSF test, so we can look at the CSF or we can do a lumbar puncture, like we will stick a needle into the back, take some fluid out, test it out, and say, okay, this person has elevated or amyloid in the brain. And we can kind of do the same thing with the p-tau levels. And Quest came up with this blood test that you can actually just go get it done yourself, which we don't really advise because we still have some concerns about the methodology and how they're counseling people before they get results of this test. That's a big deal. If someone comes and says, someone has Alzheimer's, they should have appropriate counseling. Laurie.
So now that these tests are available, and I heard about it at a banner function that long ago, that a lot of these are they have a whole battery of tests now at the Banner Alzheimer's Institute. What do you do if it shows that you're at risk? Is it a depends on how old you are now and how your cognitive functioning is now? But when you get the test, what do you do? What do you
Great
tell the
question.
patients to do?
So right now, we don't have medications. Okay. I'll come back to the question about what the medications can do. But if we do identify people with, let's say we have not really gone so far in testing everybody for the p-tau levels. But if we do even do the ApoE test and we don't have anything to offer them, they don't have any symptoms, we don't have treatments to offer, I would emphasize on lifestyle factors. We talked about like how this is a balance between, or not a balance, but it's contribution from both sides, from environmental side and the genetic side. Then we would talk about like what all you can do to improve your outcomes. So exercising regularly, eating healthy, keeping your heart in a good condition, making sure your blood pressure, diabetes, high cholesterol is addressed well, sleeping well, all those things is what we would talk about. But we'll talk about the medications in a little bit.
Okay.
So we'll jump into the medication. So in our world, we talk about medications in two categories. Symptomatic therapy, which is what we have majority right now, which is things like the medications you will take to improve the symptoms, but not necessarily to change the course of the disease itself. It doesn't change the pathology of the brain itself. So that process will continue to go on. And disease modifying treatment is where we are going to change the process and change some of those uh, pathology that's happening in the brain. So this is going to be a busy slide. I'm sorry, but I just want to kind of emphasize like where the field is. So this is kind of the overview of all the clinical trials that's going on in Alzheimer's disease. So this inner circle is phase 3, which is much closer to getting out. Phase 2 is the phase before that. Phase 1 is mostly animal study and early human studies, or animal studies is probably somewhere outside there. This is very early human studies. So you can see that the biggest pie is the disease modifying biologics and disease modifying small molecules. So these two constitute about 67 to 70% of all the drugs that are being tested out. And then we have some, this is all the symptomatic treatment for just cognition. And then there is some symptom-based treatment for psychiatric problems like depression and anxiety and dementia. So things that you want to be aware of in this field is this medication called aducanumab. The reason why it's not something that's popular, and in fact, they're going to be phasing it out over the next year or so, not in the next 6 months or so. But what this medication did or showed was that this class of medication can remove amyloid from the brain very well. So this is baseline. This is everybody at the start of everyone getting the treatment or enrolling in the study. And this is 1 year after. So this is the comparison for people who were on placebo. They did not receive the medication. This is one who got 3 milligram per kilogram, 6 milligram per kilogram, 10 milligram per kilogram. Okay, so these are comparisons. Red is good, which means, oh, sorry, red is bad.
Bad.
Red means that they have amyloid. The amyloid is what is lighting up the red. So you can see the placebo stayed the same. 3, it's already a big difference, like the way things, it gets removed much of amyloid. And there's a dose dependent thing. So you can see almost clearance here in the 10 milligram per kilogram dosing. There was a lot of controversy with this medication. The FDA gave an accelerated approval. And then because of the other molecules that we have come to be approved, they're going to withdraw this medication from the market. One of the side effects on this class of medication is this something called as ARIA. So it can cause brain bleeds like this or brain swelling like this. So this is something serious. So we'll have to really carefully watch. We've been very cautious in rolling out this medication. So the one that is the most popular now is called the lecanemab. This is they showed that the risk of ARIA was about 12% compared to 2% in placebo. And most of the people don't have any symptoms. Only about 3% would want to have symptoms. But it did slow down the decline by about 27%. Well, let's just go to the next slide. So this is exactly what it means. So it is what we were hoping for, is that it would stop the disease progression, which it did not. So it slowed it down. So people who on placebo continued to decline, and lecanemab also declined, but over time they were different. So if you draw a line from that 18-month mark as to where lecanemab was to where the placebo arm was, that's about 13 months. So that's about 5 months gain, right? Like people who took the medication were about 5 months better off compared to people who took the placebo. Lori, let me finish the slide and I'll come to the question. So they got a full approval in July. So we finally started infusing April of this year. So it took about like 9 to 10 months for us to get this going. So CMS eventually came to agree to cover the cost of the medication, and they're also going to cover the cost of PET scans that it needs to be done. Okay, Rory.
I was just saying, it seemed that other drugs seemed like it was so effective at removing a lot of the amyloid and plaque that, I mean, so effective that wouldn't it be worth a small risk of a bleed, because that can also be addressed? I mean, what's worse, to have full-blown Alzheimer's or to potentially have a small bleed or stroke? Again, I think it's, well, that's the way I think. I think it's,
Yeah.
is
Well,
it acceptable?
Yeah, that's a great question. I think that's very individualistic, right? Like some people may be okay with it. Some, it's not worth it. But I want to clarify, lecanemab, this medication also has the same risk of having this brain bleed and brain swelling. Now, let me turn this thing now. It is not a cure, right? Like these medications are not a cure for Alzheimer's. So it just slows it down. Now, the question is, these are infusions every 2 weeks. So would you want to go get an infusion every 2 weeks to slow down the decline, not stop the disease, and still take the risk of having brain bleeds and brain swelling? For some, it may be worth it, and they really have seen the worst of this disease in their family and they want to get it done. For some, they would rather not do it. Let's say someone in their late 80s, they don't want to mess with it. Not everybody, but some people may not have the same drive to mess with it. So it's not for everyone. I'll leave it at that. We went over this. Donanemab. This is just hot out of press. This got approved today by FDA.
Wow.
So this is the other molecule similar to the lecanemab. Again, anti-amyloid. It removes the amyloid from the brain. Very good in removing the amyloid. Again, slow down the decline by some. Doesn't stop the disease. And this will get rolled out very soon now. Barbara, you had a question.
Is the lecanemab the same as Aricept?
No. So
Is the other
Aricept,
one?
sorry?
No, go ahead, please.
So Aricept or donepezil, rivastigmine, memantine are all, they belong in this cognitive enhancer group. They just improve the symptoms. They don't affect the disease progression at all. So the symptomatic treatment.
Thank you.
Yeah. So great question. They have been in market for 20, 30 years now. We use that routinely, and they can be used with lecanemab, but different way of mechanism of action. Prevention trials. So this is one thing I was going to refer to, Laurie, to your question. What can you do if you have these markers? So we are now moving to this field where we are wanting people who have these markers but don't have symptoms to participate in these clinical trials. So we're essentially giving lecanemab in the AHEAD and donanemab in Trailblazer to see if we can delay or stop or prevent Alzheimer's from happening in the first place. So this should read out in a couple years, both these trials. This one was a negative study. It was a weaker molecule. It did not really do well. So this was the first prevention study that we ran, and that did not pan out well. So these two things are going to be very important for us to look out to. So in the future, if one of these things show that it can stop or prevent or even delay the development of Alzheimer's, someone has one of those markers, we would let them get on to one of these treatments, clear out the amyloid, and see if they do well. I'm going to switch gears from medications to interventions. So we talked about like how important it is to avoid hypertension or address hypertension. So this was a very important study called Sprint Mind study. So there, most of the recommendations would be 140 over 90 as the goal for treating hypertension in older adults. So this study just said, let's have a goal of 120 instead of the 140 and see how that'll impact things. Will that lower risk of dementia and MCI? So they did show that people who were at a tighter control of their blood pressure were at a lower risk of having MCI and dementia compared to people who were on this 140 cutoff. So a lot of trials have sprung out of that clinical study, so there's more going to come in. The other study that had garnered a lot of attention was this finger trial, which was the first randomized control trial, which is like, you assign people into different groups and follow them over years and to see if this multi-domain intervention has any benefit. So interventions were nutritional guidance, physical exercise, cognitive training, social activities, management of their vascular and metabolic risk factors. And after just 2 years, their cognition improved by 25% in this multi-interventional group. There's a lot of good evidence to show that these interventions can be very helpful. So I think I put this slide for just to go over the intersection between dementia and schizophrenia. So Emil Kraepelin is one of these guys who is kind of credited for coming up with a lot of initial information about schizophrenia. In fact, he called this as dementia precox. I felt like this was really tying up the whole thing together. They didn't know this was schizophrenia. They didn't call this as schizophrenia initially. It was someone else, I think. I don't remember who was that, who came up with schizophrenia. But Kraepelin called this as dementia precox. They identified this as a psychotic illness with progressively getting, progressive disease progression and having chronic cognitive and functional deficits. So there's a lot of parallels between dementia and neurodegenerative diseases, but it is not as progressive as the neurodegenerative diseases like dementia. But you will see these neurocognitive deficits even in people who don't have florid psychotic symptoms, who are in the pre-phase of schizophrenia. You will see some cognitive deficits even earlier. There are some really good studies done to show that people who eventually progress to dementia tend to have cognitive effects even before. And over time, people who have schizophrenia tend to have a higher risk of developing dementia, 10 to 20 times higher risk compared to people with the general population. Some studies have shown like a faster decline in cognition, but others have not found the same thing. Okay, I had some notes here. So why do people think this happens? Like, why is there like all these people with schizophrenia tend to get worse over time? So one thing is low cognitive reserve. So there are some studies which have looked at how much what we call as cognitive reserve is in people, and when you start off being under being below what we would expect for age, your risk of having dementia, or when things get worse over time, it's easier for you to progress to that category of having dementia, because you're already starting at a lower point to begin with. And sometimes there's also this accelerated cognitive aging. We think that people tend to age cognitively faster. Like they may have physically, they may be progressing at the same time, but they tend to get worse, or some of those symptoms that we heard as part of natural aging can present earlier in people with dementia, with schizophrenia. I kept the number of points up low so that I can look at the notes. So that's probably what I'm trying to scroll down. There's also, people with schizophrenia tend to have a higher incidence of cerebrovascular disease. They tend to have, there's this social drift hypothesis when they have less availability of good food, good exercise programs, and things like that. So the risk of metabolic syndrome is higher. They also have lower physical activity from the beginning just because of the symptoms itself. And again, availability of good mechanisms to engage in healthy lifestyle. But they also have a higher risk of cerebrovascular disease. And then you add on medications which are going to increase the risk of having cerebrovascular or cardiovascular risk factors. Like we have second generation antipsychotics, which increase your risk of weight gain, hyperlipidemia, diabetes. So all those things can contribute to higher vascular burden in the brain. The other thing is the antipsychotic medications. They can have their own side effects, like anticholinergic side effects can happen with a lot of these medications. So it becomes, it's obviously necessary for us to prescribe medications to people with schizophrenia, but they also come with side effects and they can contribute to a faster decline in their cognition over time. So that's kind of like the last slide I have for this session, but I also want to just give a shout out. We have a Project Echo series. So if you're a provider and you have a panel of, or you see patients with dementia, we have a 6-month program where we meet every 2 weeks for an hour. So we have a small didactic presentation, about 15-20 minutes, and then we take a case from the people who attend who attend these sessions, and we discuss that as a team and say, okay, this is how I would have managed. So you learn based on the cases. So if you're interested, we are booked out for the rest of the year, but we have spots starting January of 2025. So if you're interested, you can scan this QR code and register if you're interested in that.
I see a question in the chat. They
sorry.
want to elaborate on the cognitive reserve. And I think we talked a little bit about it when people highly educated have a lot of cognitive reserve. People that often have some of these diseases don't attain the same education level, right? Or as others.
That's okay. I'll just stop this so that I can look at the chat too. It's very confusing for me. I'm sorry, we use Teams quite a bit. So I do use Zoom for Project Echo. Okay. Yes, so that's exactly right. Think about it this way. So the more activities you do in your brain, the more circuits you're going to build within the brain. Like you're connecting different parts of the brain constantly. So you have more resilience in the brain for things like, so if one part of the brain gets affected, you have others to compensate. And so you can just keep going without much symptoms. And that's kind of like what we refer to as cognitive reserve, the amount of reserve capacity you can tolerate without getting an impairment.
There was another, I was listening to a podcast and they were talking about sleep and people that have disruptive sleep. So like say doctors that run in and are on call, or people that are world travelers that have jet lag, and how destructive that is long term, and what a big factor it is for disease if you don't have consistent repetitive sleep.
Yeah, sleep is one of the other major. I think we went probably briefly touched on this as to what things that we want to counsel people as to what they need to do. Sleep is very important. People with obstructive sleep apnea or other type of sleep disturbances have shown that actually their amyloid levels are higher, even in the brain scans. So there's like a biological um, evidence for that too. Psychedelic drugs. There is, but not enough to kind of have any generalized things. So some of them are actually even now in clinical trials. So nothing where we can have some meaningful um, recommendations or results yet.
Okay, any other questions for the doctor? I mean, it was a great presentation. If you can send me the slides, I'll put the slides up for those that missed them.
Okay. Yeah, I can.
Yeah, this is Mike Franzak. I have a question. That was a very wonderful presentation. One of the things we're looking at is health equity. Is there any data that you're aware of showing differences in racial, ethnic groups with respect to Alzheimer's?
Yeah, great question. So absolutely. There's plenty of evidence which actually shows that people who are either in Latinos or African Americans are 2 to 3 times more risk of having dementia, Alzheimer's disease, than non-Hispanic white population or even Asian population. Some of this is attributed to social things, like, I mean, again, education levels are different. The other thing is just access to healthy lifestyle is a very big change. And the third thing is vascular risk factors. People tend to, in these ethnicities, tend to have more cardiovascular risk factors like hypertension, diabetes. So they're at higher risk of having dementia.
Well, thank you.
Yeah. Can you talk about or touch on the nun study as well and what they found with all of these nuns that had dementia after their death, or had clinical signs of it, but didn't manifest it during their life?
Yeah, that was a fascinating study. I blank out on all the details of it. So this was a group of nuns who volunteered for this study, and they showed really well about like what are the, again, environmental risk factors, things that like education, healthy lifestyle, what are those things, and the impactful in development of dementia in that cohort of nuns. Yeah, it was one of the early studies which really showed the emphasized the um, importance of environmental risk factors.
Yeah. That they got up every day and they were in service, so they never knew what they were going to deal with. So they were testing their brains on being resourceful, helping the community, and that they had a tight social community too.
Mhm.
And they worked, so they got exercise in, right? And
Yeah,
things. So
yeah. I mean, not everybody did. I think some people did. So I think that's where
Yeah.
they could see the difference.
Yeah.
Yeah.
Okay, any other questions? Well, this was great. So happy that you were able to present, because I thought it was just such a interesting and fascinating subject. And I can't wait until we all go in and get tested. Oh, we do? No, I thought that was a ham, but it isn't. But I'd love to go in. So can you ask your doctor during your physical that you want the testers for markers for Alzheimer's?
Not yet. You could, but I think they may send you to this Quest Diagnostics or something like that. But that'll happen in the next couple of years, I think.
Okay. Well, thank you. If you'd like to stay on, you can, but after this portion, I usually turn off the recording and then we hear from some either providers that are in the room. We have a couple docs in the room, or others that are having trouble right now with their loved ones, typically in the behavioral health system, but sometimes in the physical health world as well. But
Got it.
I want to thank you. Again, we appreciate taking the time coming to talk to us. Thank you.
Thanks, Laurie. I appreciate you inviting me.
Thank you.
I'll have a good meeting. Thanks.